Can a keyhole retrosigmoid approach safely reach the petroclival region while preserving the neurovascular structures? Common sense will simply challenge the question, but common sense is not always the answer. I am Rafael Martinez-Perez, and in this video I demonstrate the MiniRISA technique, a minimally invasive retrosigmoid intradural suprameatal approach recently featured in Operative Neurosurgery for the resection of a specific type of Petroclival Meningiomas, those arising from the tentorium and the petrous apex. This is not a standard retrosigmoid approach. Today I will show how the MiniRISA technique expands the retrosigmoid corridor through drilling the suprameatal tubercle, allowing access to the Meckel scape and the petroclival junction through a focused keyhole exposure. By the end of this video, you will understand why this minimally invasive approach can become an effective shortcut for selecting medium-sized petroclival meningiomas receiving vascular supply from the tentorium and the petrous apex, including tumors extending into the Meckel scape. This is an older adult patient presenting with progressive hearing loss and imbalance. Imaging demonstrates a 3x2 enhancing lesion at the petroclival region with extension into the cerebellopontine angle. The patient is positioned in a 3/4 prone park bench with a slight head elevation to promote venous drainage and improve visualization. The shoulder is tapped anteriorly while the head is slightly rotated ipsilateral to maximize the maneuverability. A curvilinear incision is made approximately 2 finger breadths posterior to the pinna. A musculocutaneous flap is elevated in layers. The asterion is used as a landmark to identify the junction at the transverse and sigmoid sinuses. Using a diamond drill, both sinuses are partially exposed to optimize the retrosigmoid corridor. It's important to note that at least 50% of both sinuses needs to be exposed in order to maximize dural retraction. The dura is open in a Y-shaped fashion, extending towards the transverse and sigmoid junction. Dural leaflets are then reflected and secure, maximizing exposure while maintaining a limited craniotomy. This step is critical to create sufficient working space within a keyhole approach. With gentle cerebellar relaxation and opening of the cister, the tumor capsule is identified. Dissection proceeds inferiorly to locate the 7 and 8 cranial nerve complex. In cases with significant mass effect, anatomical orientation might be challenging and careful dissection identification is required. The Geisinger line is an imaginary line that marks the inferior margin of the internal acoustic canal. The suprameatal tubercle lies just superior to the IC and represents the bony protuberance located over the entry of the facial and vestibulocochlear nerves. Internal debulking is performed using a low-profile suction device, allowing efficient work with a narrow corridor. This debulking facilitates tumor collapse and improves access to deeper attachments. Feeding vessels from the tentorium and the petrous surface are coagulated and divided to reduce the vascular permeability. At the tentorial level, coagulation is performed cautiously until key structures such as the forecardial nerve and superior cerebellar artery are clearly identified. The tumor capsule is progressively mobilized and separated from the brainstem while preserving the arachnoid planes. Attention is then directed inferiorly, where the tumor is carefully dissected away from the facial nerve. Stepwise decompression allows for safer manipulation and reduced traction on critical neurovascular structures. At this stage, the suprameatal tubercle limits the visualization of the tumor extending towards the middle cranial fossa. Under continuous irrigation, the bone is drilled using a diamond drill to avoid thermal injury to adjacent cranial nerves. Removal of this structure expands the corridor and enables access to the full tumor extent. This schematic highlights how the suprameatal tubercle can obstruct the line of sight and how its removal improves exposure to the Meckel scape and the petrous apex. Following adequate exposure, the remaining tumor is removed, including involvement of Meckel scape when present. A gross total resection consistent with Simpson grade 1 is achieved. The final view demonstrates preservation of critical neurovascular structure within the petroclival region. Dural closure is performed in a watertight fashion using a graft and further reinforced with the hydroxyapatite bone cement. Care is taken to minimize tension and prevent postoperative CSF leakage. Post-op MRI shows gross total resection. The patient did well with temporary facial weakness that fully resolved at 3 months post-op, and improvement of gait imbalance and becoming fully independent at 3 months follow-up. Once again, thank you for watching. If you enjoy advanced skull-based anatomy and microsurgical techniques, consider subscribing to the channel and joining our growing neurosurgical community at RMP Skull Base. Thank you and have a nice weekend.